the magnitude of birth defects of heart, I will concentrate about the Indian scenario, naturally because I live and work and practice here. However, the African situation you must be well aware of. So if you compare the subcontinent here in India and the continent of Africa, which is rather large, big one, but with slightly less population that India is, the magnitude you can extrapolate in your own conditions. In India, we know from the census in 2009 that every year nearly 200,000 children are born with the congenital heart defects in this country, and of which 60,000 would require treatment within the first year of life. And the sad part of the story is that only 5,000 get treatment because of several factors, namely the lack of awareness amongst the general public, general physician, and even the doctors who are scattered all over the country. So the major factor is the delayed diagnosis. And indeed, that India, although is quite rapidly developing in the recent years, but is still facing a challenge of poor socio-economic status of nearly 67% of the population, and that causes delayed treatment. Now, what are the things which are required at our end? From the doctor's point of view, what we need is highly trained and dedicated team of diagnostic facilities. We need, that's the cardiology part. Then we need a highly skilled surgeon and highly skilled and dedicated nursing to look after these babies. Now, unfortunately, I know that in Africa also the situation is rather much worse than India, that the poor availability of these facilities, even in the best of the hospitals, is coming in the way of improving this scenario. And financially, this is not one of those cardiac surgical subspecialty that provides a lot of money, because as we all know from our own cultural setups, that producing a baby is rather much easier than actually generating wealth to look after them. And therefore, most of the private setups do not undertake congenital heart surgery in their setups, and if they do, actually the adult cardiac surgery programs in these institutions provide the money and the finances to run those programs. Then another important thing is the lack of trained manpower, as we discussed earlier. Oh, I need to, right. So, the first part of this lecture we'll discuss the symptoms of the congenital heart disease. So, there are 9 subheadings that we will discuss the symptoms. The first is the neonatal history. Now, neonatal history as soon as the child is born, the most important symptom that the pediatrician, gynecologists, and even sometimes parents notice is the cyanosis, or the baby having difficulty in breathing. So, we can take this history from the child if we are a general practitioner or if we are a pediatrician working in the community. However, if these two symptoms are present or may not be present, we can always dig into the patient's history or the baby's history, that if child needed to stay in the hospital after the maternal discharge for one of these two symptoms. Let's discuss now the cyanosis part. Now, cyanosis is a very important symptom of something not right with the heart structurally. Cyanosis develops when there is more than 5 gram% of deoxygenated blood in the baby's circulation. However, in cases where the child has got polycythemia vera or polycythemia due to any condition, this could be falsely positive. If the child is born to an anemic mother and also have lower hemoglobin because of the malnourished mother that to which he or she is born, it could be falsely negative. That means the cyanosis may not appear in an anemic baby. So these are the two fallacies that one has to be very aware of, that if the child is polycythemic or if the child is anemic, you may be misled by not being able to diagnose or overdiagnose this symptom. The pathophysiology which leads to the occurrence of cyanosis is due to the obstruction of systemic venous blood flow to the lungs, because the blood is not getting through to the lungs and not getting oxygenated. Shunting of deoxygenated blood, that means from the right side into the left side, and that causes the mixing of the deoxygenated blood into the oxygenated blood on the left heart, will also cause cyanosis. And similarly, desaturation due to any reason of the already saturated blood but is getting desaturated and not returning in time for saturating inside the lung circulation will also lead to the same problem. Now we will discuss the symptom of failure to thrive. This is indeed a very common scenario, especially in malnourished families and communities, that the child do not fail to thrive. But failure to thrive because of a cardiac pathology is a very important thing, and this will lead to a delayed milestone, and that is primarily because of the poor cardiac output, increased myocardial energy consumption, and poor feeding due to the first symptom. If you remember, I said difficulty in breathing. So the child is not able to maintain the oxygenation while breathing. As you would know, that when the child sucks the mother's nipple or feeds himself, we all have to stop breathing. When we are already having problem with the circulation and deoxygenation or over circulation to the lung, then feeding is affected, because the child would like to have more breathing to oxygenate himself and maintain the cardiac output. Now exercise, obviously the kids do not do exercise, but what we call as exercise intolerance in case of babies is that the baby fails to suck and feed himself. Or if the child is grown up, say a toddler, the child may be more sedentary compared to his peers, may not like to play, and if at all likes to play, may not be able to keep up with his peers. Now pathophysiology leading to this exercise intolerance is basically related to the poor cardiac output, because the cardiac output he cannot maintain, and increased energy consumption by an overworked heart. Now shortness of breath, we discussed a little briefly earlier also. Some children may not be may be short of breath without appearing in distress. That means they are happily tachypneic. Here is the role of the parents and school teachers also, that they notice that the child breathes rather more fast compared to his peers whenever he is even at rest, sitting in the class or moving around. A pathophysiology of shortness of breath is because of the increased pulmonary blood flow, which leads to the membranous pulmonary edema, which is subclinical and does not allow the oxygenation to take place because of the interstitial edema. Then when the shunting is taking place from right to left, the decreased oxygen diffusion and hypoxemia may also cause the shortness of breath. The sixth Our seventh symptom is syncope. Syncope, as you all know, is the darkness and little unconsciousness because of the inability of increase the cardiac output to maintain the cerebral circulation. And this could be because of the restricted left ventricular outflow. That means with kids born with the severe aortic stenosis, aorta is on the left side and aorta is connected to the left ventricle, and if the left ventricle is pumping through the stenosed aortic valve into the systemic circulation, then the cerebral circulation is affected. And at any time when the child requires to increase his or her cardiac output for any physical or emotional activity, the cardiac output cannot keep up the pace with the child's activity, and the child may get dizzy, darkness in front of his eyes, and become very transiently unconscious, and that's all is syncope. Abnormal vasomotor tone resulting from vasodilatation, when vasoconstriction is needed to maintain adequate blood flow and pressure, is also one of the reasons. You may have noticed that people in very hot weather, sometimes when they are sitting or lying, suddenly get up, they get the disease spell, and that is a very physiological syncope because of the vasodilatation, inordinate vasodilatation. The eighth symptom is palpitation. Now, palpitation, we all know, is irregular rhythm, tachycardia, or awareness. Even when you are having a normal heart rate and rhythm, you are well aware of your heartbeat, and that is called as palpitation. Now, what is the reason that this palpitation is an important symptom of diagnosing a congenital heart disease baby? The last symptom could be the chest pain. Now, chest pain is a very funny symptom in babies. We don't normally ascribe chest pain for babies and toddlers. However, many of the kids, they do complain about the chest pain. It's rarely of cardiac origin, and hence it is usually not taken very seriously. And therefore, this chest pain must be excluded to have a cardiac origin. That means that if a child is complaining of chest pain or pain in the region of the heart or precordium, we must take it seriously and exclude the cause, cardiac origin. Look for the extracardiac cause, establish a cause, and if it is not there, we must always think that it could be because of the cardiac reason. In that case, we look into this seriously. Now, coming to the signs of congenital heart defects, we are all very much aware of the signs, symptom, and signs are elicited by inspection, palpation, and auscultation. It's a very standard medical flow pattern to diagnose things. So first of all, we will discuss the inspection part. Now, inspection is, we should look for whether the child appears ill. Usually the babies who are having a cardiac defect will appear ill compared to the normal babies, because they have decreased tissue oxygenation, poor cardiac output, or cyanosis. They will have respiratory distress. If the shunt is from the left to right, they will have overcirculation, and that will cause pulmonary edema and also hypoxemia. As we discussed, cyanosis, peripheral edema because of the right heart failure, distended neck veins. The neck veins of the baby will be distended because of several reasons, one of which could be tachypnea, labored breathing, shortness of breath, or because of the right heart failure. The right-sided pressure is more, and then prominent neck veins will help you to diagnose a child who is not even complaining of any distress. Now, clubbing of the digits, that means the club of the digits become, the tip of the fingers become clubbed, they become swollen because of the increase in the peripheral tissue under the nail bed. Then sometimes chronic peripheral tissue hypoxemia because of the low cardiac output can also give rise to the cyanosis, but that should be differentiated from the central cyanosis of shunting with the poor cardiac output cyanosis of peripheries. Coming to the palpation part, the next step is always palpation after the inspection is done. The peripheral perfusion normally should not take more than 1 to 2 seconds. Now, if you press the nail bed or the tip of the finger of a child or the tip of the toe of a child, the paleness of the tissue should immediately become red. I do not know how many of you can see, but you can see in my finger it becomes pale, but within a second it becomes red again. So that will tell you the condition of the peripheral perfusion, and this can also be a good symptom to check in any patient where you feel that the circulation is affected because of the cardiac reason. Now, normally the reflection of cardiac output is that femoral artery pulse with the brachial artery pulse must be palpated simultaneously. So femoral artery and brachial artery will give you an idea if they are simultaneously jerking. That means you do not have an obstruction somewhere in the large artery connecting the left heart to the peripheries of the body, and that is usually because of the coarctation. If it is normal, full, that means the child, at least we exclude the coarctation of the aorta, or the shunting because of the patent ductus arteriosus. In patent ductus arteriosus or something that is causing a diastolic runoff, that means aortic regurgitation, the pulse will be more bounding. However, when it is a very thready pulse, that means the bounce of the pulse is less either in the limbs, that means the legs or the upper limbs, that means the cardiac output is less, or there is an obstruction either at the level of the aorta, arch, aortic valve, or distally. Now, how do you palpate the precordium? You palpate the precordium by the flat of your finger. Always put the flat of the finger rather than the fingers. Complete palm over the top of the precordium is the right way to palpate the precordium. If the cardiac output is increased due to the left to right shunt, there will be ventricular hypertrophy, or the precordium will be hyperactive. If there is a turbulent flow because of the obstruction, you may also feel at the palm the thrill sometimes when the grade of the murmur is more than 3:5. Now, what are the indicators of ventricular hypertrophy or atrophy that you can also feel sometimes by the hyperactive or inactive precordium? Because the kids have a very thin chest wall, it's easier to feel the heart touching the anterior chest wall and your palm. In aortic stenosis, that is congenital aortic stenosis, the turbulent flow through the ascending aorta, through the aortic valve, you can always feel a suprasternal notch thrill. So if you put your finger, just the finger here in the suprasternal notch, you will feel the thrill that is coming from below the aortic valve, ascending aorta, and to the arch here. Hepatomegaly, the enlargement of liver, you can check below the right and the left costal margin. But always remember, in a newborn or an infant, normally you can feel the liver because the liver size is bigger than the chest cavity, and therefore the liver always protrudes a little, half to 1 centimeter below the costal margin. So one should always be aware of this fact while looking for the hepatomegaly. Now, coming to the auscultation part, pulmonary edema you can always listen with the help of your stethoscope the ralls and the crackles. You should be aware of the first and the second heart sound, and first heart sound, as you know, is due to the closure of the AV valve, and AV valves are mitral valve and tricuspid valve. Second heart sound is produced by the aortic and pulmonary valve, and there are two components in the second heart sound. One is the aortic component and other is the pulmonary valve component. If for any reason you feel or you hear that the second heart sound is single, that means one of the valve is not working appropriately or has not developed appropriately. It could be an aortic single sound, or it could be a pulmonary single sound, depending on which valve is involved. In a transposition of great arteries, that means when the aorta is behind the pulmonary artery or it has rotated, that means you cannot hear the other valve sound even if it is normally there. So in transposition of great arteries, usually the aorta is behind the pulmonary artery, and therefore the P2 component of the heart sound is only heard. Sometimes when you see that there is a split of the heart sound which is little wider, that means the pulmonary and the aortic components are split apart, it could be a very important finding in children who have a large ASD. A gallop rhythm, S3 and S4 are not very important for a general physician, nurse or a doctor, primary physician. It is for the specialist pediatric cardiologist who can identify S3 and S4, and therefore we will not discuss in detail. Now, obviously, as I mentioned earlier, a stenotic or a dilated valve which is leaking behind will cause a murmur. Murmur is produced by the turbulent blood passing through the stenosed or a regurgitant valve. These murmurs are graded into 1 to 6 or sometimes 1 to 4, depending on what system you choose to classify them. Now, any murmur which is, as I said, 3 to 4 grade you can always feel as a thrill on your palm when you put your hand on the precordium. Now, murmurs are two types, systolic murmurs and diastolic murmur. So let's look at the systolic murmurs. Holosystolic murmurs are the one which actually fills up the entire systole of the cardiac cycle, and that is because of the shunting of blood between the two heart chambers. The pressure on one side is always higher. That means, depending on the kind of pathology that you are facing, but normally is the left side which is the higher pressure, and the right side is the lower pressure because it is pumping blood into the lungs, so the blood will circulate. However, when there is an obstruction on the pulmonary valve, that means the obstruction to the right heart cardiac output, then the right sided pressure is more than the left side, and the blood will flow from the right to left. So you can have a holosystolic murmur. In ventricular septal defect, which is a very common heart defect, you will definitely hear a harsh murmur in the third and the fourth space on the left side of the baby. The atrioventricular valve regurgitation, that means mitral as well as tricuspid, usually they are softer murmurs. Now, murmurs could be ejection type. Ejection murmurs are because of the turbulence at the level of the valves, that means aortic and the pulmonary valves. So when these valves are obstructed, the blood ejecting through these valves will produce an ejection murmur. Usually it is produced in aortic stenosis, pulmonary stenosis, and sometimes it can be confused with a high small VSD. Unfortunately, this slide is not coming up very well, so we'll skip that and we'll go to the next the normal heart and its echo. Now echo, here you can see that this is the right heart, that is the right atrium, where all the blood from the SVC, the IVC is collected, and it goes into the right ventricle, and from the right ventricle it goes into the pulmonary artery, and pulmonary artery then goes on the either side into the lungs. The pulmonary veins collect the blood from the left and the right lungs, put that into the left atrium, and then this blood comes into the left heart and then goes into the aorta, the main vessel of the heart, supplies into the brain and into the limb, upper limbs, and from the descending thoracic aorta it goes down and supplies the lower part of the body. Now in this echo still picture you can see all these four chambers divided by, or you can see this thing, this is basically right and the left heart, and this is the right atrium and the left atrium. Now one of the commonest defect could be at the level of the atrium. I do not know whether you can see the moving picture here, but the upper chambers, that means here the upper chamber, these are the lower chambers, that the ventricle. Here the upper chamber, if there is a defect here, you can see the catheter going in. So if the defect is at the level of the atrium, that's known as the atrial septal defect. Now it can be secundum type or primum type, and these are the very intricate things which medical students, nursing staff and the paramedical staff, I understand that's my audience, need not know the intricacies of this, but the defect at the level of the upper chamber is called as atrial septal defect. Coarctation of the aorta is another very common condition, and these kids who have coarctation of aorta usually present very sick. They are very sick because the cardiac output is not allowed to move into the lower part of the body, which is the larger part of the circulation. And when you can see that the coarctation here is an obstruction, the blood is ejected from the left heart into the aorta, into the arch vessel, but cannot go down into the aorta, and that's why this coarctation is taking place. It can sometimes be present between these two great the branches of the arch of the aorta, and then it is known as preductal, and this is postductal. That means beyond the duct, and that is before the duct. When it is preductal, you will see that because it is preductal, one of the arm will not have the adequate amount of circulation, and you will have the difference in the blood pressure on either arms. The point here is that you should know that one must always take blood pressure whenever you suspect that the pulse in lower limb and the upper limb is different in volume, or right and the left pulse are different. That means you have to take the pressure in the left and in the right arm, and with this simple basic test of taking blood pressure in lower limb, upper limb and right and left limb, you may be able to diagnose a coarctation, which is sometimes a very deadly condition in small children. This is ventricular septal defect. Is, as the name itself is suggestive, is the defect between the two ventricles. That means the right and the left ventricle. And as you can see that the defect in the muscular part of the interventricular septum, apical part, and here you can see, maybe this is a little smaller diagram, but if the ventricular septal defect is situated in the upper part, it's known as perimembranous VSD. This echo picture is very clearly showing you the ventricular septal defect between the ventricle, right ventricle, and this is the left ventricle, and the VSD is somewhere here. So this is a very common condition, and so common that many a times this is diagnosed. This particular defect is diagnosed the earliest. Another common condition that is diagnosed the earliest is the patent ductus arteriosus. Patent ductus arteriosus is basically a duct that is essential for life of the baby when the child or baby is inside the mother's womb, because this duct provides the circulation. Because the lungs are not functioning, as you know, mother is breathing for the baby, so the lungs are non-functional, and therefore all the pulmonary blood flow goes out from this duct into the circulation. However, when the mother delivers the baby, and the baby now on its own has to breathe to maintain its own oxygenation, this duct naturally becomes smaller and then becomes and closes by the end of 1 month, sometimes latest by 1 month. So if it remains patent, we call it patent ductus arteriosus. Now this patent ductus arteriosus, as you would understand, because the pressure in the aorta is more compared to the pressure in the pulmonary artery, the blood will flow from the aorta into the duct, and if that blood flow flows into the duct, it will be a very high pressure, and because of the high pressure it will be much more than the required blood flow into the lung, and that will cause pulmonary blood flooding. This flooding is causing the overcirculation, and overcirculation will cause pulmonary edema, difficulty in breathing, failure to thrive, failure to shortness of breath, and all these symptoms because of the overcirculation. Usually it is diagnosed early, and once diagnosed, a very simple operation is required, and that operation is tying the duct or clipping the duct, and sometimes division and suture of the duct. And cardiologists can also sometimes put a coil. As you can see here, this is a coil which can be put inside the duct through a catheter which goes from the aorta and then from the femoral artery puncture, and they can place a little coil here or a device that is known as a Rashkin device and can close this duct. Pulmonary stenosis, again a very common condition. Now you should be able to interpolate that if there is a stenosis of the pulmonary valve, the ejection from the right ventricle will not be able to go into the lungs for proper oxygenation. And if the child cannot oxygenate himself or herself properly, obviously the child cannot grow, cannot feed properly. The child will be tachypneic, child will have failure to thrive symptoms, and sometimes can be cyanosed also, depending on how critical the pulmonary stenosis is, because when the right-sided pressure will be high, the foramen ovale will continue to be patent and will shift the blood from the right to the left sometimes, and that will cause cyanosis, central cyanosis. Pulmonary stenosis is usually a condition which the cardiology friends can deal with very easily by putting a balloon through the catheter into the femoral vein. They go into the femoral vein, into the IVC, then into the right ventricle, put the balloon across the pulmonary stenosis and can dilate. Once they dilate, the pulmonary blood flow starts to take place into the lungs, and the child will then start growing well, and tachypnea will decrease, the right-sided pressures will come down. However, sometimes, and this is we are talking about isolated pulmonary stenosis, but when the pulmonary stenosis is associated with other critical heart condition, that will be dealt separately. Now, pulmonary stenosis is a condition which can be dealt with balloon only when it is of the pulmonary valve. But when there is stenosis is lower down, that means in the infundibulum, muscle growth has taken place, the balloon may not provide adequate relief to the child pulmonary stenosis, but that we will discuss later on. Similarly, in the aorta, the similar condition will cause aortic stenosis, and aortic stenosis will directly affect the cardiac output from the left heart, so the baby will be very sick. This can also lead to baby's death, untimely death soon after birth, if it is very critical, and if it is also associated with the ascending aorta and arch hypoplasia, and then in that case it is called hypoplastic left heart syndrome, because in that case the left ventricle will not develop properly even in the mother's womb when the child is developing. Coming to the atrio-ventricular valve, I am not sure how many of you know the embryology of the heart. It's rather complex, but the heart develops in a tube, in a straight tube, and then it rolls, the tube rolls over itself and makes the right and the left ventricle. The left ventricle behind, the right ventricle in the front, pulmonary veins in the back, left atrium in the back. So the tube, the vertical tube rotates itself like this, and the heart is formed. In the tube, the valves also develop from the endocardial cushions. When they do not develop properly, the AV canal defect or the atrioventricular canal defects develop, and this will lead to abnormal development of mitral as well as tricuspid valves. And when this condition is present, as you can assume, because the atrioventricular valve is at the junction of the atrium and the ventricle, there could be an atrial septal defect, a ventricular septal defect, and the abnormal tricuspid and mitral valve. So it can be a very complex situation, and these defects can be of various subtypes associated with very other complex anomalies and can be a life-threatening. However, the simplest of the AV canal defect is the primum type of the ASD. That means the primum ASD is slightly different from the secondum ASD, that the ASD is very low down near the mitral and the tricuspid valve junction. In that situation, mitral valve usually will have a cleft, not necessarily always, and it's a very simple defect to manage surgically. It cannot be managed. A primum defect cannot be closed through a catheter or a cardiological device. Now, this is one of the most common condition. The blue baby syndrome is commonly called. That is called as Tetralogy of Fallot. Tetralogy of Fallot is the commonest and the most rewarding heart surgery, at least to me, I feel. Baby comes blue. Your cardiologist diagnoses the condition. The child, you operate, and the baby becomes pink soon after surgery, and starts to play well, grows well, and can be a very rewarding operation for surgeon, for parents, for his friends and peers, and to the family. In this defect, there are 4 problems in general. One is the presence of the ventricular septal defect. Second is the presence of the obstruction because of the deviation of the septum. It causes pulmonary stenosis. It can be muscular pulmonary infundibular stenosis, or the valvular, or both. The pulmonary artery may or may not grow fully because of the lack of blood flow starting from the child, from inside the womb. Then there is a rotation, as I said, malrotation of the heart, and so all these things can cause cyanosis. Now, this is one condition which must be diagnosed properly and counseled to the babies properly, because unless we do that, we can delay the operation, and presence of deoxygenated blood in a baby for a longer period of time affects the growth of the child, even if we correct it later, because cyanosis will affect the development of the brain. Cyanosis will affect the growth of the baby, so the child will never be able to enjoy the full potential of his capabilities in the later life. So ideally this operation must be performed in less than a year that I do, usually between 6 months to 2 years ideally should be performed. And once you correct this deformity, the child becomes pink, has normal oxygenation, and can grow and develop fully to his or her potential. Transposition of great arteries, as I alluded to you earlier part of this lecture, is a condition where the normal relationship of the aorta is sandwiched between the pulmonary artery, slightly behind. Pulmonary artery is front, aorta is slightly behind. This relationship is changed. Now this relationship can be anywhere between the 360 degrees, but usually aorta is in the front. Pulmonary artery is in the front and the aorta comes diametrically opposite, anteroposteriorly. And this is one defect because now the aorta is connected to the right ventricle instead of left ventricle, and pulmonary artery is connected to the left ventricle. The transposition has taken place. The blood, instead of going from right atrium to right ventricle to pulmonary artery to lungs, then left atrium, left ventricle, and then into the aorta, that is a serial circulation. It goes into a parallel circulation. And in parallel circulation you can interpolate that if the parallel circulation is taking place, the oxygenation will not take place. So we need that mixing of the both sides of the blood for survival. Now if for any chance this mixing is not taking place, cardiologist can, if the pediatrician diagnoses immediately after birth this defect, can make a little hole into the atrium that we call as atrial septostomy, and can make the child to live if there is no ventricular septal defect. However, many children are also born along with a ventricular septal defect and a transposition of great artery, and when that is present, the natural mixing is taking place and child can live, at least to that stage where the child can be diagnosed. Now the problem here is that even if the child lives, the ventricles are not working. The right ventricle is working for the systemic circulation, the left ventricle is working for the pulmonary circulation. They regress. They assume the function, they assume that they have to work for life like this, and therefore the left ventricle will regress accordingly for the pulmonary circulation, and the right ventricle will become thicker for the systemic circulation. And this is a very problematic situation, that even when you correct, if this regression has taken place, even if you correct the anatomy, the ventricle will not take load immediately following surgery, and therefore these operations must be done within 2 months of age, ideally within 2 months of age, if the ventricular septal defect is present. And therefore it brings us to the fact that this condition must be diagnosed earlier, following soon after birth. However, when the ventricular septal defect is not present, that means there is an intact septum, the child will require fenestration, atrial balloon septostomy, or if an ASD is already present, then surgery within 2 weeks of birth. And that is also a very highly technically demanding surgery. So, and not only that if we don't do the surgery early, then the heart is not going to take a load. You can see this little balloon going from the IVC, trying to create a hole into the intraatrial septum for adequate mixing of the blood for the child's survival. Do we have time? Excuse me? Is there any time? Can I continue? How long can I continue? Huh? How long? To go? I think I have got. As I said, the heart develops from a tube and it rotates upon itself to make a heart. Similarly, the aorta and the pulmonary artery which are connected to the heart also develop from a tube, and when they do not take proper development or take partitioning properly, the single artery that remains because of the absence of septation is called truncal arteriosus, truncus. Now the valve, obviously pulmonary and aortic valve are not present because it's a single tube, and that valve is also known as truncal valve. Now you can presume that if there is only a single artery present taking the output from both the right and the left ventricle, and if we want to correct this defect, we have to have an artificial artery connecting from the right ventricle to the lungs, and therefore here comes the need of either an artificial conduit taken from an animal or from a dead person's heart, that is we call homograft. And when we do such surgery, we put this single artery committed to the left side and the conduit artery committed to the right side, and do the rest of the operation. As you can see in this slide, the right ventricle is now committed through this tube into the pulmonary artery, and the truncal artery is now committed only to the, so the VSD that is present between the two, because both the ventricles are now, earlier were pushing the blood into the truncal artery, we have to close the VSD also. Tricuspid atresia, it's very simple to understand that one of the tricuspid valve, that means atrio-ventricular valve, the right-sided valve is the tricuspid valve, the left-sided valve is the mitral valve. The tricuspid valve has failed to develop. It's atretic. Now, as I told you earlier, that when the aortic stenosis, aortic hypoplasia is present, the left ventricle does not develop. Similarly, when the tricuspid valve is stenosed, has failed to develop itself, then the right ventricle does not develop. And here you will have a single ventricle situation. Of course, there are many classifications, sub-classifications, and the complexities of tricuspid atresia, but not going into those details. One fact one must remember, that if the right ventricle is not there or not developed properly, the heart has got a single ventricle, the both sided blood will be mixed together, and the child will be born cyanosed. Child will be born blue. So this is one of those conditions. Transposition of great arteries, tricuspid atresia are two conditions in which you now know will be born with a blue blood, and because they are blue, it is important that we diagnose these conditions right at the time of birth so that we can deal with them as quickly as possible. Conversely, the tetralogy patients are not born blue. They develop cyanosis later on. So maybe in the first month or two months later, they develop cyanosis as the pulmonary artery stenosis grows, and when the pulmonary artery stenosis grows, then the right to left shunt starts taking place. Pulmonary atresia, the same thing, like aortic atresia, pulmonary atresia, that means the pulmonary valve is not developed or is so severely stenosed that there is no output to the right ventricle, and in that case there will be a VSD. The right ventricle will come or eject its blood into the left ventricle, and the left ventricle will then eject its blood into the circulation. These kids are also very sick babies. Total anomalous pulmonary venous connection. That means the pulmonary veins which are supposed to be draining into the left atrium fail to develop properly or connect abnormally. When this condition happens, the child will be born blue. So again, this is one of those conditions when the child is born blue, and these three conditions, transposition of great arteries, total anomalous pulmonary venous connection, and tricuspid atresias, these three conditions must be diagnosed at the time of the birth if the doctor attending to the mother or the baby is alert. And these are very much amenable to surgery if performed in the right manner, at the right place, at the right time. Hypoplastic left heart syndrome. is a very debatable condition, and many centers are not there in the world. There are very few centers where this condition is can be successfully treated. It requires a staged operation. One operation is done immediately following birth. Usually, if the baby is diagnosed preterm, that means before birth, inside the mother's womb, the surgeon gets prepared to deal with this situation, and they operate this child. First stage, second stage, and the third and the final stage is the Fontan correction. The mortality is very high, even in this, and the many of the children do not attain the third and the final correction, and even if they do, very few survive in long term. Now, Ebstein malformation. Ebstein malformation is one condition where the tricuspid valve is abnormally developed. It's there, but it's abnormally developed. This is also a condition in which a complex surgery is required, but if it is diagnosed properly in proper time, now there are methods to deal with this abnormality very successfully. So in general guidelines, who is moving the cursor? General guideline is that blueness at the time of birth, immediately after birth, murmur, rapid breathing and low pressure must be diagnosed at the time of birth. If it is within 2 to 6 months, difficulty in feeding, blue nails, inadequate weight gain, recurrent chest infection must be taken seriously. Then if the baby is diagnosed within first 3 years of life because of the fainting spell, that means syncope, abnormal heartbeats, that means arrhythmia or palpitation, child avoids vigorous activities, unable to play with his mates and keep up with his peers. So these are the things one should be aware as a physician, as a nursing person or a paramedical staff to diagnose in community. What are the things that a mother should be advised to avoid during pregnancy? One is isoretinione, thalidomide, estrogen, oral contraceptives, ACE inhibitors, chloramphenicol, chlorpropamide, erythromycin, tetracycline and haloperidol. These are the drugs which must not be taken by a mother who is pregnant, because if she does, the child is likely to be born with a congenital defect. Anti-cancer drugs and phenytoin are also harmful. Now you know that phenytoin is taken by those who have epileptic disease. So one has to be very careful, and the physician must be aware and to weigh the risk and the benefits of phenytoin and anti-cancer drugs against the development of heart defects in the babies. Epinephrine, ephedrine, beta blockers, promethazine are really not very harmful, but the research says that they could be potentially harmful drugs for a mother. So in the end, I will say that there are million times more patients in the world with congenital heart defects now that we have almost eradicated polio, but the world government's total budget for polio is many thousand times more than they spend on congenital heart defects. And therefore, if you multiply that, the gap is more than the billion magnitude. Therefore, we must do something more. We should diagnose these babies as early as possible to make our community healthier and the future brighter. I thank you all for attention and listening to my lecture.